Hello everyone. I welcome you all to Pediatrics Made Easy by Dr. Mayank Pahuja. Today, as I told you in my last video, that today we'll be discussing MISC in children and all about COVID-19 in children and adolescents. In my last video, I discussed about everything basics, mild, moderate, severe, in whom to get tested, why to get tested, when to suspect COVID. So now I'll be discussing about MISC. So let's discuss what is MISC. MISC is multi-system inflammatory syndrome in children. Now, so coming on to the definition, what is MISC? As per WHO, MISC definition is in 0 to 19 years of age group when fever is more than 3 days and any two of the following. What are the points? Among all these points, any two of the following, that is rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammation signs, that is oral, hands or feet. So similar finding everyone knows that we get in Kawasaki disease also. So these COVID patients can also present as Kawasaki disease because we get rash, non-purulent conjunctivitis and mucocutaneous junction involvements in Kawasaki as well. Next is hypotension or shock. Third is features of myocardial dysfunction, pericarditis, valvulitis, or coronary abnormalities, including echo findings or elevated troponin levels or anti-pro-BNP levels. BNP is brain natriuretic peptide. That was the indication which we mentioned in the severe COVID in children. We mentioned that we need to get a 2D echo also done. So that is the importance of 2D echo because the echo findings, okay, echo findings is one of the criteria which is present in MISC. Next is evidence of coagulopathy, which can be checked by checking PTTT and elevated D dimers, that there is coagulopathy or not. In this era of COVID, almost everyone knows that what test to get it done. It is available everywhere. D dimers, CRP quantitative, everything, everyone knows. So this is very common. So these basically are just mentioning here because we should know what does these tells. Everyone is getting them done, but importance is why to get it done. So elevated D dimers, T levels tell us about evidence of coagulopathy. Any acute GI problems like diarrhea, vomiting, or abdominal pain. So out of these, any two, if they are present along with fever with more than 3 days in a 0 to 19-year-old child. So this is one of the criteria. And what we should know that here it is written acute GI problems. So acute GI problems, that means we should not miss or we should suspect. Should keep, as I told in my last video, we should keep a high index of suspicion if patients are there who come to you with diarrhea, vomiting, or abdominal. Please keep a high index of suspicion in COVID in your mind, because if you treat it generally like you treat it like viral gastroenteritis, but your brain should know and should be alert that yes, this could be COVID, or there are high chances of probability of this child having COVID. So we should be alert to keep a watch that this patient doesn't land into moderate or severe, or if at all patient is landing, you should know that this patient needs what extra care he should need if this is COVID positive. Next, and along with elevated CESR, C-reactive protein, or procalcitonin, any one of them. Next, and no other obvious microbial cause of inflammation, including bacterial sepsis. See, all of these findings, these rashes, hypotension, shock, coagulopathy, if patient goes in DIC due to sepsis, elevated ESR, CRP, or procalcitonin, they can present in any bacterial infection also. So you have to rule out that there is no other bacterial infection like staph or streptococcal shock syndrome. So you have to rule out that there is no bacterial sepsis, as I told in my last presentation as well. So we should know that there is no other, in absence of the other bacterial infections, if these conditions are present, and the last criteria is evidence of COVID-19, RT-PCR, antigen or serology positive test, or likely contact. If patient is in likely contact with patients with COVID-19, suppose both parents are positive, then you have to think that it becomes a valid point that child must be positive. So we have what we have to see: the age group 0 to 19, fever with more than 3 days, and just remember that there is no or, here it is and and so all of the things are present, should be present, and in this criteria any two of the following should be there. Okay, so this makes the definition and whole completes the criteria for multi-system involvement, multi-system inflammatory involvement syndrome. Okay, next is coming on to investigations. What are two investigations to be done? So there are basically two tier of investigations, tier 1 and tier 2. In tier 1 investigations, we have to do CBC, LFT, RFT, but blood glucose, blood gas, CRP and or ESR, SARS-CoV-2 serology also, PCR. Okay, workup for other infection, we have to rule out other infection as well as I just told, malaria, dengue, blood culture for any other bacterial sepsis, scrub typhus, leptospirosis. In tier 2, I'll be telling when to get tier 1 investigations done and when to get tier 2 investigations done. Cardiac में ECG, echo, BNP, trop T levels, inflammatory markers like procalcitonin, prothrombin, PTT, D-dimer levels, fibrinogen levels, LDH, triglycerides, ferritin, and interleukin 6 levels. So when do we say that tier 1 is positive? Either both to be present or and no other diagnosis. Okay. Now what is this? Both is 0.1 and this is 0.2. Both should be present. That is CRP is more than 5 milligram per DL and oblique, or ESR is more than 40 mm per hour. So either of the two or both. Okay, CRP and ESR, either of the one is should be positive, along with ALC. ALC is absolute lymphocyte count. This is emerging as a very important tool. If it is less than 1000 microliters, platelet 1.5 micro, or sodium levels less than 135 milliequivalents per liter, or neutrophilia or hypoalbuminemia. Okay, so platelet is less than 1.5. So along with this, both should be present, either CRP or ESR or both, along with this absolute lymphocyte count, platelet and sodium levels, or there is neutrophilia. Many people are seeing these days neutrophil to lymphocyte count ratio. So this is one and the same thing, that ALC is less than 1000 and there is increased levels of neutrophils. So coming on to the algorithm, what this algorithm tells us, that if there is MISC, shock or life-threatening disease is present or not. We have to see that first. So if there is shock or life-threatening disease and there is no shock or life-threatening disease, so what is the difference? What we have to see, that in cases of when there is shock is present, or any life-threatening disease is present, we have to give IVIG. Dosage is 2 gram per kg over 24 to 48 hours. Maximum which has to be given is 100 grams. And okay, there is and IV methylprednisolone 10 to 30 mg per kg per day. Maximum dosage limit is 1 gram per day, and empirical antibiotics needs to be started. Aspirin 3 to 5 mg per kg per day, maximum 81 mg per day. It is contraindicated again if platelet is less than 80,000 or there is any bleeding. Now, if there is no risk, coming on to no shock, or there is no shock, or there is no life-threatening disease. So what has to be done in this case? If there is no shock or life-threatening disease, IVIG same has to be given, just like if there is presence of shock. If methylprednisolone has to be given, it has to be given in dosage of 1 to 2 mg per kg per day, maximum 1 gram per day. You just have to see, only difference is IV methylprednisolone, here it is 1 to 2 mg, here it is 10 to 30 mg per kg per day. Now, if IVIG is not possible, only methylprednisolone can be given. Rest of the treatment remains same, empirical antibiotics, aspirin, and contraindicated. Aspirin is contraindicated again if platelets are less than 80,000. Now, if in this category we see if there is shock or life-threatening condition is present, we do this. Yes, in cases if there is evidence of coronary aneurysm, that is Z score is more than 10, or thrombosis, or there is left ventricular ejection fraction is less than 35%. In those cases, we have to give enoxaparin 1 mg per kg BD subcutaneously. So this is one of the indication of giving enoxaparin. Okay. So why we have to give enoxaparin? Okay. So no response. Now coming here, if there is no response, whether it is a patient with shock or life-threatening disease, whether there is no shock or no life-threatening disease, if there is no response after 72 hours, what we can do, we can repeat IVIG, and what we can do else, we can give tocilizumab. Okay, tocilizumab can be given, and one is tocilizumab can be given 4 to 8 mg per kg per dose, or high dose anakinra 2 to 10 mg per kg per dose subcutaneously, or IV it can be given every 6 to 12 hours. Another option is giving infliximab, more than 6 years old. We have to give that dosage 5 mg per kg IV at 0, 2 and 6 weeks. Till date, we people, what we are mainly using is tocilizumab here if there is no response after 72 hours, and other options are using these drugs. Next is steroids to steroids. Methylprednisolone can be shifted to oral dextromethorphan after 3 to 5 days of methylpred. We can taper 25% every week, and we have to stop within after 3 to weeks. Eco 1 to 2 weeks and 4 to 6 weeks. 2 times has to be done, and as required otherwise. At least twice it has to be done in first to second week, and in between 4 to 6 weeks. These are the two timings when eco has to be done. If there is no response, what we call as that, when we say that there is no response, here we mentioned that no response after 72 hours. So what is definition of no response? Definition of no response is either fever is persistent and or ongoing and significant end organ involvement. There is end organ involvement and or significantly elevated inflammatory markers just like IL-6, CRP, ESRs. Okay, so this is all about MISC. I hope everything is very clear. I try to make it very simple. So next is, this is all about MISC. I hope you like the video. If you like it, do like it, share and subscribe. Yes, and together, if we all try, don't stop wearing mask even if you are vaccinated. Don't stop social distancing, because these are only the keys from which we can prevent further spread. Already it has spread a lot. These are the only things which help a lot. Thank you.